Welcome to this video entitled, Opportunistic Infections Management and Prevention. We will now discuss a few key concepts. 1. The epidemiology of opportunistic infections in human immunodeficiency virus, HIV, disease has changed considerably with the introduction of effective antiretroviral drugs. 2. Prevention of opportunistic infections is of prime importance to prevent morbidity and mortality from infections and to limit deterioration of the host control of HIV viral load and accelerated loss of T cell number and function. 3. Clinical features of opportunistic infections can be challenging as the degree of immune compromise can alter typical presentation of disease manifestations. 4. First-choice treatments and alternative regimens for most opportunistic infections are now quite effective, and the outlook for patients presenting with these HIV-associated opportunistic infections is better, particularly when combined with early institution of effective antiretroviral therapy. 5. The adverse effects of immune reconstitution inflammatory syndrome, IRIS, from beginning antiretroviral therapy, ART, can be severe, e.g. initial treatment of cryptococcal meningitis with antifungal agents and antiretroviral therapy, and this problem must be factored into the timing of treatment of opportunistic infections. 6. Preemptive therapy and maintenance therapy against recurrence of opportunistic infections are indicated in selected patients with early HIV infection and in advanced acquired immunodeficiency syndrome, AIDS. As a way of introduction, the major cause of death in patients with AIDS had been the opportunistic infections, abbreviated as OIs, that arose as a consequence of the severe immunodeficiency characteristic of HIV infection. Since the advent of the era of potent antiretroviral therapy, abbreviated as ART, there has been a marked decrease in the occurrence of AIDS-related opportunistic infections and a consequent increase in survival. Nevertheless, there is great variability in access to antiretroviral therapy, and consequently significant AIDS-associated opportunistic infections continue. In the Western world, this is largely a consequence of delayed diagnosis, with patients presenting with an opportunistic infection as the first recognition of HIV infection. In resource-poor situations, availability of antiretroviral therapy is more of a problem. The number of circulating CD4 plus T lymphocyte count is closely correlated with the risk of developing several opportunistic infections. Once the CD4 plus T lymphocyte count falls below 200 cells per microliter, the cumulative risk for developing an AIDS-defining opportunistic infection is 33% by year 1 and 58% by 2 years. Therefore, CD4 plus T lymphocyte counts are the critical parameter for monitoring patients who have HIV infection because of their predictive value for both opportunistic infections and mortality. Two patterns of opportunistic infection development exist: re-emergence of infections acquired early in life, often in childhood, as the CD4 plus T lymphocyte count falls, and newly acquired infection by organisms that become pathogenic in the setting of progressive immunodeficiency. The probability of developing a given disease depends on the risk for exposure to potential pathogens, the virulence of the pathogens, and the level of immunosuppression of the patient. There is a wide geographic variability in the epidemiology of opportunistic infections. In the USA and Northern Europe, pneumonia caused by Pneumocystis jirovecii, abbreviated as PJP, oropharyngeal or esophageal candidiasis, cytomegalovirus disease, and infections caused by Mycobacterium avium complex, abbreviated as MAC, are common. The incidence of toxoplasmosis and tuberculosis is higher in Eastern and Southern Europe and in the low and middle income countries, depending on the prevalence of latent infection in the general population. We will now discuss the use of antiretroviral therapy during management of acute opportunistic infections. Antiretroviral therapy should be initiated as soon as possible in patients with opportunistic infections for which treatment is limited or not effective and for whom the overall improvement of immune function would be beneficial. Examples of such conditions include cryptosporidiosis, microsporidiosis, progressive multifocal leukoencephalopathy, and HIV-associated dementia. For patients for whom definitive anti-infective therapy is available, the benefit of immediate initiation of antiretroviral therapy in increasing CD4+ T lymphocyte count and improving the patient's immunologic status must be weighed against the possibility of increased adverse effects, toxicities, or drug-drug interactions. Randomized clinical trials demonstrated a clinical and survival benefit of starting antiretroviral therapy early, within the first 2 weeks, of initiation of treatment for an acute opportunistic infection. The majority of opportunistic infections were PJP and serious bacterial infections, and some caution must be taken extending this recommendation to tuberculosis, where the risk of immune reconstitution inflammatory syndrome, abbreviated as IRIS, may be higher. Cryptococcosis is the only exception to this rule, as early initiation of antiretroviral therapy is associated with higher mortality. See section on cryptococcosis. We will now focus on prophylaxis of opportunistic infections. Preventive therapy for OIs was the mainstay of treatment in HIV prior to the introduction of effective antiretroviral therapy and remains important for patients with severe immunodeficiency, even when antiretroviral therapy-associated immune recovery can be expected. Certain principles underlie the decision to use prophylaxis for different pathogens, namely: 1. The incidence and prevalence of specific infections in HIV-infected individuals. 2. The potential severity of disease in terms of morbidity and mortality. 3. The level of immunosuppression at which each disease is likely to occur. 4. The feasibility and efficacy of preventive measures, and in particular their impact on quality of life and survival. 5. The potential for emergence of organisms resistant to the agents used for prophylaxis. 6. The risk of toxicities and drug interactions with antiretrovirals and other drugs used by HIV-infected patients. 7. The issue of compliance. And 8. The cost-effectiveness of prophylaxis. As an example, PJP is very common, causes significant mortality and can be easily prevented. As a result, routine prophylaxis is recommended for all HIV-positive patients with CD4+ T lymphocyte counts less than 200 cells per microliter. In contrast, candidiasis is also very common, but rarely causes mortality, is easily treated, and prophylactic antifungals are associated with a significant risk of resistance, so prophylaxis is rarely given. Cryptococcal meningitis is associated with significant mortality and is preventable using fluconazole. However, prevention is not regarded as cost-effective in the West because it is relatively rare. In contrast, primary prophylaxis is justified in areas such as sub-Saharan Africa and Southern Asia. We will now focus on the duration of prophylaxis against opportunistic infections. Susceptibility to opportunistic infections can be accurately assessed by the CD4+ T lymphocyte count. It is therefore possible to stop primary or secondary prophylaxis in patients whose immunity has improved as a consequence of highly active antiretroviral therapy, abbreviated as HEART, and whose T cells have risen above the threshold of increased susceptibility. This is particularly true for patients with complete viral suppression, as ongoing improvements in immune function can be expected. By contrast, no data are available regarding the reinitiation of prophylaxis when the CD4 plus T lymphocyte count decreases again to levels at which the risk for opportunistic infections exists. In particular, it is unknown whether it is better to use the threshold at which prophylaxis was stopped or the threshold below which initial prophylaxis is recommended. We will now focus on pneumocystis jirovecii pneumonia, abbreviated as PJP, pneumocystis jirovecii, previously known as pneumocystis carinii, and still often referred to as pneumocystis jirovecii pneumonia for pneumocystis pneumonia, is a fungal pathogen associated with opportunistic infections, especially pneumonia, in patients with altered cell-mediated immunity. Historically, the occurrence of pneumocystis jirovecii pneumonia in American gay men who had no previously known immune deficiency was the first signal of the AIDS epidemic. Although the implementation of prophylaxis and the advances in antiretroviral therapy have markedly decreased its incidence, pneumocystis jirovecii pneumonia remains an important opportunistic infection. Its epidemiology is uncertain, although it is generally thought to be due to reactivation of latent infection acquired during childhood or adolescence. Genetic studies of pneumocystis jirovecii isolates suggest that recent exposure to environmental strains may be a factor in acquisition of infection. Pneumocystis jirovecii pneumonia typically occurs when the CD4 plus T lymphocyte count is less than 200 cells per microliter. The rate of relapse after a first episode of pneumocystis jirovecii pneumonia is high, approximately 60% incidence within 1 year, when neither specific prophylaxis nor highly active antiretroviral therapy, abbreviated as HEART, is initiated. We will now discuss clinical features of pneumocystis jirovecii pneumonia. Pneumocystis jirovecii infection is restricted to the lung in more than 95% of cases. The most common clinical presentation of pneumocystis jirovecii pneumonia is a progressive dyspnea with dry cough, fever, often mild, and weight loss. On examination, fever and tachypnea are common, whereas lung auscultation may be normal or reveal only basal crepitations. Disseminated infection, bone marrow, spleen, liver, retina and skin, can occur spontaneously or in association with the use of aerosolized pentamidine. Chest radiography is an important step in the diagnosis, being normal in less than 5% of cases of pneumocystis jirovecii pneumonia. The most common pattern is a fine bilateral interstitial and then alveolar interstitial infiltrate progressing from the perihilar to the peripheral regions, as shown in Figure 94.1. In advanced cases, progressive consolidation with air bronchograms and complete opacification of the lungs may develop, as shown in Figure 94.2. Numerous atypical patterns of pneumocystis jirovecii pneumonia may occur. They include localized infiltrates, cavitary lesions, solitary lung nodules, spontaneous pneumothoraces and pleural effusions. Hilar or mediastinal lymphadenopathy is very rare. Establishing a diagnosis of pneumocystis jirovecii pneumonia requires the morphologic demonstration of the microorganism. Arterial blood gases must be measured to assess the severity of the disease, but have no diagnostic value. Sputum examination is the least invasive procedure for collecting lower respiratory specimens. Because patients who have pneumocystis jirovecii pneumonia generally do not have a productive cough, an induced sputum can be obtained after aerosolization of hypertonic saline, ideally under the supervision of a physiotherapist. In routine practice, the sensitivity of the test is approximately 50 to 60%. Fiber optic bronchoscopy with bronchoalveolar lavage is the reference routine diagnostic procedure because its sensitivity is more than 95% and its specificity is 100%. When the diagnosis cannot be obtained from bronchoalveolar lavage fluid, transbronchial lung biopsy may help, although it is more invasive and is associated with a risk of bleeding and pneumothorax. Pause the video and carefully scrutinize Figure 94.1 illustrating mild pneumocystis jirovecii pneumonia before advancing to the next slide. We will now discuss the management. The measurement of arterial gas is used routinely to define mild, that is a PaO2 equal to or greater than 70 mm of mercury, moderate, PaO2 50 to 70 mm of mercury, and severe, that is a PaO2 less than 50 mm of mercury, pneumocystis jirovecii pneumonia. Hospitalization is generally required with the exception of some cases of mild pneumocystis jirovecii pneumonia, for which outpatient management with oral therapy is often possible providing no other disease is present. There is low risk of drug malabsorption, the management strategy is well understood and the patient is aware of the potential side effects of therapy. Trimethoprim sulfamethoxazole, abbreviated as TMPS-MX, is the drug of choice for pneumocystis jirovecii pneumonia whatever its severity, and no other drug or combination of drugs has demonstrated improved efficacy in controlled trials. The drug is given as 15 mg per kilogram per day trimethoprim with 75 mg per kilogram per day sulfamethoxazole, in 3 divided doses. Side effects include rash, fever, pruritus, digestive disturbances and cytopenia, usually after 7 to 10 days of therapy. Approximately 10 to 20% of patients will need to be switched to another treatment because of trimethoprim sulfamethoxazole intolerance. It is important to determine the nature of intolerance to trimethoprim sulfamethoxazole. In practice, contraindication to reintroduction of trimethoprim sulfamethoxazole or to the use of a combination with potential cross-intolerance to sulfonamide is based on a history of anaphylaxis or exfoliative dermatitis or other life-threatening toxicity such as severe cytolytic hepatitis. Whenever possible, the first-line therapy for pneumocystis jirovecii pneumonia is always trimethoprim sulfamethoxazole. For cases of mild pneumocystis jirovecii pneumonia, alternates include dapsone plus trimethoprim, clindamycin plus primaquine or atovaquone. For more severe pneumocystis jirovecii pneumonia, alternates include clindamycin plus primaquine or intravenous pentamidine. In addition to anti-pneumocystis jirovecii therapy, corticosteroids are administered as soon as possible in patients who have moderate to severe disease. The use of corticosteroids is recommended in patients whose PaO2 is less than 65 mm of mercury and has been shown to improve oxygenation, reduce the risk of fibrosis, decrease the need for mechanical ventilation and reduce the case fatality rate. The recommended corticosteroid regimen is on days 1 to 5, 40 mg oral prednisone, prednisolone, every 12 hours, on days 6 to 10, 40 mg oral prednisone per day and on days 11 to 21, 20 mg oral prednisone per day. In most cases, respiratory symptoms and oxygenation improve after 5 to 10 days. If a patient has been treated empirically, without definitive diagnosis, failure to improve after 5 to 7 days of treatment should trigger a re-evaluation, usually with bronchoscopy. Early mild deterioration is not infrequent during the first days of treatment. The duration of treatment is classically 21 days. When trimethoprim sulfamethoxazole is initiated intravenously, it can be switched to an oral formulation after a few days. Secondary prophylaxis is required after treatment of the attack. Pause the video and carefully scrutinize Figure 94.2 illustrating severe pneumocystis jirovecii pneumonia before advancing to the next slide. We will now discuss prevention of pneumocystis jirovecii pneumonia. Prophylaxis against pneumocystis jirovecii pneumonia is indicated for all HIV-infected patients with a CD4+ T lymphocyte count less than 200 cells per microliter or those with a history of oropharyngeal candidiasis or an AIDS-defining illness. Trimethoprim sulfamethoxazole is the drug of choice while offering a significant reduction in bacterial infections as well as a primary prophylaxis against toxoplasmosis. Side effects are sufficiently severe to require discontinuation of the drug in 25 to 50% of trimethoprim sulfamethoxazole recipients. There is good evidence that lower doses of trimethoprim sulfamethoxazole are better tolerated, and many advocate either the use of lower dose regimens using one single strength tablet daily or one double strength tablet thrice weekly. Patients who have adverse reactions to trimethoprim sulfamethoxazole usually tolerate dapsone. Of note, secondary prophylaxis for cerebral toxoplasmosis with pyrimethamine sulfadiazine or a regimen including atovaquone provides an adequate primary prophylaxis for pneumocystis jirovecii pneumonia. Primary and secondary prophylaxis against pneumocystis jirovecii pneumonia may be discontinued in patients treated with HART who show an increase in CD4+ T lymphocyte count to above 200 cells per microliter for at least 3 months. Prophylaxis should be reintroduced if the CD4+ T lymphocyte count decreases to less than 200 cells per microliter. Of note, in an observational European cohort, incidence of pneumocystis jirovecii pneumonia was low and independent of prophylaxis in patients with CD4+ T lymphocyte count between 100 and 200 cells per microliter with a viral load below the limit of detection. We will now discuss viral infections. Most clinically important viral infections in HIV disease are caused by DNA viruses, the majority belonging to the herpes viridae family. The role of viral infections such as human herpes virus 8, Epstein-Barr virus and human papillomavirus in HIV-related neoplastic disorders is discussed elsewhere. We will now focus on cytomegalovirus infections. Serologic evidence of cytomegalovirus, abbreviated as CMV, infection can be detected in approximately 60% of the adult population in the USA. The prevalence of infection is strongly influenced by socioeconomic status and sexual practices. Up to 95% of men who have sex with men, abbreviated as MSM, are seropositive for CMV. In patients who have AIDS, CMV disease usually results from reactivation of latent infection. Progressive loss of cell-mediated immunity in patients abrogates the immunologic suppression of CMV replication. Asymptomatic excretion of CMV in urine can be detected in approximately 50% of patients who have advanced HIV disease, and over half of the patients who have CMV viremia go on to develop clinical CMV disease within 8 to 12 months. Cytomegalovirus end organ disease usually occurs when the CD4+ T lymphocyte count falls below 50 cells per microliter. We will now discuss cytomegalovirus retinitis. Retinitis is the commonest manifestation of cytomegalovirus infection in patients who have HIV infection or AIDS, accounting for 85% of cytomegalovirus disease. The virus causes a relentlessly progressive, necrotizing retinitis. Cytomegalovirus retinitis is usually unilateral in the first instance, progressing to affect the contralateral eye if untreated. Patients may be initially asymptomatic but may subsequently experience blurring of vision, floaters and painless progressive visual loss. Diagnosis of cytomegalovirus V retinitis is made by systematic fundoscopic examination by direct or indirect ophthalmoscopy. Characteristically, white, fluffy or granular lesions with perivascular white exudates associated with retinal edema and hemorrhages are seen, as shown in Figure 94.3. We will now discuss gastrointestinal cytomegalovirus disease. In the upper gastrointestinal tract, cytomegalovirus causes discrete esophageal ulcers, diffuse esophagitis, gastritis, gastric ulcers, duodenal ulcers and enteritis. Esophageal cytomegalovirus infection usually presents with painful dysphagia. Diagnosis is established by endoscopic examination showing inflammation and ulceration, with characteristic pathologic features on tissue biopsy. Cytomegalovirus enterocolitis usually presents with abdominal pain and persistent small volume diarrhea. Endoscopic examination of the colon typically reveals plaque-like pseudomembranes, multiple erosions and ulcers. Pause the video and carefully scrutinize Figure 94.3 illustrating cytomegalovirus retinitis, with characteristic perivascular hemorrhages and exudates before advancing to the next slide. We will now discuss cytomegalovirus disease of the central nervous system. The two major cytomegalovirus neurologic syndromes associated with HIV disease are cytomegalovirus polyradiculopathy and cytomegalovirus ventriculoencephalitis. Polyradiculopathy is seen in patients who have advanced AIDS. Approximately 50% have an associated myelitis. It is characterized by lower extremity pain, sensory deficits, weakness that can rapidly progress to flaccid paralysis, and bowel and bladder dysfunction. The most marked pathologic changes in cytomegalovirus polyradiculomyelitis are found in the cauda equina and lumbosacral roots. In the appropriate clinical setting, findings on MRI of diffuse enhancement of the cauda equina and the surface of the conus strongly support the diagnosis. Cerebrospinal fluid, CSF, findings include a polymorphonuclear pleocytosis, raised protein concentration and moderately low glucose concentration. Culture of CSF may be negative, but cytomegalovirus antigen assays and polymerase chain reaction, PCR, for cytomegalovirus DNA are more sensitive techniques. Ventriculoencephalitis usually occurs in the setting of a diagnosis of cytomegalovirus disease elsewhere. Patients present with fever, lethargy and confusion. Characteristic neurologic findings include nystagmus and cranial nerve palsies. MRI with gadolinium enhancement may demonstrate periventricular enhancement. Cytomegalovirus DNA can often be detected in CSF using PCR. We will now discuss pulmonary cytomegalovirus disease. There are no particular distinguishing clinical or radiologic features to differentiate cytomegalovirus pneumonitis from other causes of pneumonitis in HIV disease. Patients present with shortness of breath, dyspnea on exertion and a dry, non-productive cough. Chest radiographs show diffuse interstitial infiltrates, and hypoxemia is usually present. Definitive diagnosis of pulmonary cytomegalovirus disease in patients who have advanced HIV disease is difficult to establish because of a high incidence of asymptomatic cytomegalovirus shedding. Cytomegalovirus can be isolated in approximately 50% of HIV-infected patients undergoing bronchoscopic examination. However, the true incidence of cytomegalovirus pneumonitis is less than 10% in patients who have diagnostic bronchoscopy for evaluation of pulmonary infiltrates of unknown origin. We will now discuss management of cytomegalovirus disease. Induction therapy is based on oral valganciclovir 900 mg twice daily for 3 weeks. Intravenous ganciclovir or forscarnet may be used in case of severe digestive dysfunction or in severe cases. Ganciclovir intravitreal injections are now rarely indicated, with the possible exception of severe central retinitis. In case of retinitis, it is recommended to continue maintenance treatment with valganciclovir at a dose of 900 mg once daily for at least 3 months as long as CD4 plus T lymphocyte count has not recovered above 100 per microliter. Thereafter, and subject to the favorable recovery of retinitis confirmed by an ophthalmological examination, and negative plasma cytomegalovirus PCR, treatment may be discontinued. Ophthalmologic monitoring should be regularly scheduled, quarterly at first and less often as the host immunity is being reconstituted. There are no recommendations for secondary prophylaxis in other localizations. There is no place for primary prophylaxis of cytomegalovirus disease, but preemptive therapy with oral valganciclovir may be envisaged in case of plasma-positive PCR above 1,000 copies per milliliter, with low CD4 plus T lymphocyte counts. We will now progress to herpes simplex virus infections. Reactivation of herpes simplex virus, HSV, occurs frequently in patients who have advanced HIV disease, particularly in those who have low CD4 plus T lymphocyte counts, that is less than 100 cells per microliter. The hallmark of herpetic lesions is painful vesicular formation at a mucocutaneous site, progressing rapidly to ulceration with an erythematous base, followed by eventual healing and re-epithelialization. As patients become more immunosuppressed, infections are characterized by prolonged viral shedding, more frequent episodes, and severe and persistent clinical disease. Recurrent genital and perirectal ulcerative lesions are the most common manifestations of HSV infection in patients who have HIV disease and are usually due to reactivation of HSV2. Lesions may be atypical and severe in patients who have advanced disease. Prolonged new lesion formation, with continued tissue destruction, persistent viral shedding and severe local pain, is common. HSV infections can be treated either with episodic therapy when lesions occur or with daily therapy to prevent recurrences. This decision should be individualized based on the frequency and severity of recurrences. Most infections can be treated with oral valacyclovir, famciclovir or acyclovir for 5 to 14 days. Severe mucocutaneous HSV lesions are best treated initially with intravenous acyclovir. In case of failure or resistance, forscarnet may be used. And now we will discuss varicella-zoster virus infections. In the USA and Europe, most adults who have HIV disease have previously been infected with varicella-zoster virus, VZV. Owing to impaired cellular immunity, HIV-infected patients who have primary varicella-zoster virus are at risk of prolonged new lesion formation and are at higher risk of life-threatening visceral dissemination. Herpes zoster may be the first indication of HIV disease and can occur at any stage of HIV infection. It usually appears as a localized or segmental painful, erythematous maculopapular, then vesicular eruption along a single dermatome. In HIV-infected patients, zoster lesions may be bullous, hemorrhagic or necrotic. Patients infected with HIV are at risk of recurrent episodes of herpes zoster. Occasionally, widespread cutaneous and visceral dissemination may occur. Visceral dissemination to the lungs, the liver and the central nervous system, CNS, may cause life-threatening disease. HIV-infected patients should receive prompt antiviral therapy with oral valacyclovir, or famciclovir, for 7 to 10 days. More severe disease, extensive skin or visceral involvement, should be treated initially with intravenous acyclovir, dosed at 10 mg per kilogram every 8 hours. HIV adults who have no history of chickenpox or are seronegative for varicella zoster virus should receive varicella zoster virus immunoglobulin as soon as possible, but within 96 hours after exposure to a patient who has chickenpox or shingles. The efficacy of acyclovir in this setting is unknown. We will now discuss progressive multifocal leukoencephalopathy. Progressive multifocal leukoencephalopathy, abbreviated as PML, is an opportunistic demyelinating infection caused by JC virus, a ubiquitous DNA papovirus for which more than 70% of adults are seropositive. Progressive multifocal leukoencephalopathy occurs in patients who have deficient cell-mediated immunity and is estimated to affect up to 4% of patients who have AIDS. Mortality is high, and average reported survival in AIDS patients is 2 to 4 months. The symptoms and characteristic radiologic findings of progressive multifocal leukoencephalopathy are due to virus-induced lysis of oligodendrocytes, resulting in microscopic foci of myelin breakdown that coalesce to produce larger white matter lesions, as shown in Figure 94.4. Definitive diagnosis requires tissue from brain biopsy, but the identification of JC virus in the CSF by PCR has a high specificity for active disease. There is no definitive antiviral treatment for progressive multifocal leukoencephalopathy, and optimal ART is the treatment of choice. A paradoxical response to ART can be seen in some patients with progressive multifocal leukoencephalopathy with unexpected neurologic deterioration. Pause the video and carefully scrutinize Figure 94.4 illustrating progressive multifocal leukoencephalopathy before advancing to the next slide. Pause the video and carefully scrutinize Figure 94.5, illustrating pseudomembranous oral candidiasis, also called thrush, before advancing to the next slide. We will now discuss fungal infections. Fungi are among the most ubiquitous pathogens seen in patients who have HIV disease, but are not the most common causes of mortality. Virtually all major fungal pathogens cause disease in patients who have HIV infection. We will now discuss candidiasis. Candidal infection in AIDS is almost exclusively mucosal. Systemic invasion is a rare and late event. Oropharyngeal candidiasis occurs in about 3/4 of all those who have HIV infection. In about 1/3 it tends to be recurrent and becomes progressively more severe with increasing immunodeficiency. Esophageal involvement occurs in 20 to 40% of all AIDS patients, predominantly in patients who have advanced disease and severe depletion of CD4+ T lymphocyte counts. Vulvovaginal candidiasis occurs in about 30 to 40% of women who have HIV infection. It appears that HIV infection per se is not an important risk factor for vaginal infection, although it may influence the severity and persistence of disease. Most candidal disease, especially initial episodes, is associated with infection by Candida albicans. Other species, notably Candida glabrata, Candida dubliniensis and Candida parasilosis, tend to cause infection in patients who have very advanced disease and have had extensive previous exposure to antifungal agents. Most patients with oral candidiasis are symptomatic and complain of some oral discomfort. The classic presentation is of creamy white plaques on an erythematous base, the pseudomembranous form of thrush, as shown in Figure 94.5. Other manifestations include an atrophic form that presents as erythema without plaques, often associated with patchy atrophic glossitis, and angular chylitis, which appears as cracking, fissuring, ulceration or erythema at the corner of the mouth. Most patients who have vaginal candidiasis present with vaginal itching, burning or pain, and usually complain of a vaginal discharge. Examination of the vaginal cavity usually reveals thrush, similar to that seen in the oropharynx. Patients who have esophageal candidiasis develop ulcers and erosions of the esophagus and experience adenophagia or dysphagia. The combination of oral candidiasis and esophageal symptoms is both specific and sensitive in predicting esophageal involvement. Patients can be treated empirically with antifungal therapy. Endoscopy is reserved for those patients who fail to respond to evaluate for other diagnoses such as herpetic or cytomegalovirus esophagitis, idiopathic ulceration or resistant candidiasis. The development of oral candidiasis in an HIV-positive patient should be taken as a sign of progressive immunodeficiency. Patients should have a CD4.T lymphocyte count measured. If they are not currently receiving ART, it should be initiated. If they are on ART, it should be reassessed and, if necessary, changed. A number of options, both local and systemic, are available for the treatment of oral candidiasis. Initially, most patients respond well clinically to any form of antifungal therapy, although mycologic responses are less common. Esophageal disease requires systemic therapy. Fluconazole 200 to 400 mg every 24 hours orally for 2 to 3 weeks is the therapy of choice. In case of failure or resistance, posaconazole, voriconazole or an echinocandin may be used. Relapses are common if effective ART is not given, and at least 1/3 of patients develop recurrent mucosal candidiasis. One approach to management is to treat each episode as it occurs. However, in many patients, recurrent symptomatic disease may be sufficiently severe to warrant considering chronic suppression. Fluconazole 100 to 200 mg every 24 hours has proved highly successful in suppressing recurrent oropharyngeal disease and preventing esophagitis, and a dose of 100 mg per week can prevent vaginal candidiasis. The major risk of this approach is the possibility of developing azole-resistant disease. However, resistant infection has become very unusual in the era of potent effective ART. For a discussion of superficial dermatophyte infections, see Chapter 98. We will now progress to cryptococcosis. Virtually all HIV-associated infection is caused by Cryptococcus neoformans var. Neoformans. About 5% of patients who have advanced HIV infection in the Western world develop disseminated cryptococcosis. The disease is more prevalent in sub-Saharan Africa and Southern Asia. Most cases of infection occur in patients who have very low CD4+ lymphocyte counts, that is less than 50 cells per microliter. Cryptococcosis most commonly presents as a subacute meningitis or meningoencephalitis with fever, malaise and headache. Symptoms are usually present for 2 to 4 weeks before diagnosis. Classic meningeal symptoms and signs, such as neck stiffness or photophobia, occur in about 1/3 of patients. Some patients may present with encephalopathic symptoms such as lethargy, altered mentation, personality changes and memory loss. Analysis of the CSF usually shows mildly elevated serum protein, normal or slightly low glucose, a few lymphocytes and numerous organisms. The CSF opening pressure is elevated in 25% of patients, and this has important prognostic and therapeutic implications. About 1/2 of patients have evidence of pulmonary involvement with cough or dyspnea and abnormal chest radiographs. Most patients who have cryptococcal meningitis have positive blood cultures. Skin involvement is common and several types of skin lesion have been described. The most common form is that resembling molluscum contagiosum. Laboratory diagnosis is primarily mycological and is based on isolating the yeast by direct examination with India ink and culture of cerebrospinal fluid, CSF, bronchoalveolar lavage, BAL, blood, urine, pus and organs or surgical specimens. Identifying polysaccharide antigens of C neoformans in serum, CSF, urine or BAL is another diagnostic tool. The reaction is very sensitive and reliable in meningoencephalitis, up to 92% of positive CSF. In 2009, a new test for rapid detection of glucuronoxylamanin out of the Cryptococcus species polysaccharide capsule was developed. This easy-to-use LFA, lateral flow immunoassay, dipstick test has excellent specificity and sensitivity at least equivalent, or superior, to the conventional test. Its use as a therapeutic monitoring tool also seems to be promising. This new test also raises the value of routine screening for cryptococcosis in HIV-infected patients in endemic areas. The positivity rate is relatively high, including within asymptomatic subjects, if subjects with CD4+ T lymphocyte count less than 100 or 200 per microliter are selected. In a retrospective South African cohort, this screening allowed identification of subjects before the development of symptomatic cryptococcal meningitis with a major impact on the prognosis, thanks to the remarkable simplicity and effectiveness of preemptive treatment with fluconazole. This screening is recommended, rather cautiously, by WHO, to be considered in patients with CD4+ T lymphocyte count less than 100 microliter if prevalence of symptomatic cryptococcosis is greater than 3%. Treatment is based on the combination of amphotericin B and 5-flucytosine. A recent study confirmed the superiority of this association, administered for 2 weeks, in terms of mortality, over the monotherapy with amphotericin B. High-dose fluconazole should be used afterwards for 10 weeks. Alternative regimens are amphotericin B plus fluconazole or fluconazole plus 5-flucytosine. If CSF opening pressure exceeds 25 cm of water, lumbar punctures, that is 20 to 30 milliliters, should be performed at least 2 to 3 times weekly to maintain pressure below 20 cm of water. Steroids or mannitol are not recommended. Secondary prophylaxis with fluconazole 200 mg daily should be provided until a stable immune reconstitution is obtained. Cryptococcosis is one of the few opportunistic infections for which early initiation of antiretroviral therapy, less than 2 weeks, is associated with increased mortality. It is generally recommended to delay ART initiation to at least 4 weeks after start of antifungal therapy to avoid severe immune reconstitution syndrome. We will now discuss other endemic mycosis. Histoplasmosis is caused by the dimorphic fungus Histoplasma capsulatum, which is endemic in the Mississippi and Ohio River valleys of North America as well as in certain parts of Central and South America, Asia, Africa and the Caribbean. Coccidioides immitis is a dimorphic fungus found in the soil in the desert around the southwestern USA and northern Mexico, as well as focal areas of Central and South America. Penicilliosis is caused by the dimorphic fungus Talaromyces, Penicillium marnefae, which is endemic in Southeast Asia, especially northern Thailand and southern China. These fungi cause disseminated infection in patients who have AIDS in endemic areas, as well as sporadic infection among HIV-positive migrants from and visitors to endemic areas. The most common presentation is fever and weight loss. Pneumonia is usual in coccidioidomycosis and respiratory symptoms, cough, shortness of breath, occur in about 50% of cases of histoplasmosis and penicilliosis. Local or generalized lymphadenopathy, hepatosplenomegaly, colonic lesions and skin and oral ulcers also occur. Skin involvement is more common in penicilliosis. Involvement of the gastrointestinal tract, usually as ulcers, is a feature of histoplasmosis and may present with abdominal pain or gastrointestinal bleeding. Between 5% and 10% of patients with histoplasmosis have an acute septic shock-like syndrome that includes hypotension and evidence of disseminated coagulopathy. Meningeal disease, with symptoms of lethargy, fever, headache, nausea, vomiting and/or confusion, occurs in about 10% of patients with coccidioidomycosis. Cerebrospinal fluid analysis typically reveals a lymphocytic pleocytosis with a lymphocyte count greater than 50 per microliter. Diagnosis is made by culturing the organism from clinical specimens or by demonstrating it on histopathologic examination. In histoplasmosis, a peripheral blood smear may show intracellular organisms in white cells in many patients, and blood cultures, especially when collected using the lysis centrifugation system, are positive in over 90% of patients. Antigen detection in either urine or serum is an excellent method for diagnosing disseminated histoplasmosis. For all infections, the management strategy is similar. Patients should receive an initial period of treatment with amphotericin B for 1 to 2 weeks, until there is clinical resolution. For histoplasmosis and penicilliosis, this should be followed by itraconazole 200 mg orally every 12 hours for at least 12 months in patients on ART with CD4 plus T lymphocyte count maintained above 150 cells per microliter for 6 months. For coccidioidomycosis, fluconazole 400 to 800 mg every 24 hours orally may be an alternative for patients who have mild disease. Complete eradication is unlikely, and chronic suppressive therapy with either fluconazole 200 to 400 mg every 24 hours or itraconazole 200 mg every 12 hours is needed. Successful treatment with itraconazole or fluconazole has been reported in approximately 80% patients who have coccidioides immitis meningitis. We will now discuss aspergillosis. Infection with Aspergillus species is seen in patients who have advanced HIV disease. Specific risk factors that have been identified include neutropenia, use of corticosteroids and broad-spectrum antibacterial therapy, and previous pneumonia, especially PJP. Typically, Patients have extremely low CD4 plus T lymphocyte counts and a history of other AIDS-defining opportunistic infections. Two major syndromes predominate: respiratory tract disease and central nervous system infection. Patients with pulmonary involvement often present with cough, shortness of breath and fever. Chest pain and hemoptysis are common. Nodular infiltrates, which may be localized or diffuse and commonly cavitate, are seen on chest radiography. Additional respiratory syndromes of pulmonary aspergilloma and localized tracheobronchial aspergillosis have been reported occasionally in patients who have AIDS. Patients who have CNS aspergillosis usually present with symptoms and signs of a mass lesion or with features of a stroke due to invasion of blood vessels. Therefore, seizures, hemiparesis and focal abnormalities are common. CT scan or MRI of the head may show single or multiple lesions, usually non-enhancing, with surrounding edema. Bony invasion is common and, because the disease may have spread from involved sinuses, the sinuses may be abnormal. Patients who have fungal sinusitis usually have the classic features of sinusitis: fever, facial pain and swelling, nasal discharge and headache. CT scan of the sinuses will usually show bony erosion, and penetration into adjacent tissues such as the brain or orbit can occur. The prognosis of aspergillosis is poor, in part because of the fungal infection itself and in part because it tends to occur in patients who have advanced AIDS and many other complications of end-stage HIV infection. There is a poorer response to therapy in patients who have AIDS than in other immunocompromised patients. Voriconazole is the treatment of choice for invasive aspergillosis. We will now discuss non-tuberculous mycobacterial infections. Mycobacterium avium complex, abbreviated as MAC, bacteria are ubiquitous in the environment and have been isolated from a variety of sources around the world, including soil, natural water, municipal water systems, food, house dust, and domestic and wild animals. These isolates are thought to be the source of most human infections, but there is no evidence of Mycobacterium avium complex transmission from person to person. In untreated HIV-infected patients in the Western world, the incidence of Mycobacterium avium complex disease increases with falling CD4.T lymphocyte counts, with a cumulative probability of disseminated disease due to Mycobacterium avium complex in subjects who have CD4.T lymphocyte counts less than 50 cells per microliter of 20 to 30%, and 10 to 20% in those who have CD4 plus T lymphocyte counts of 50 to 100 cells per microliter. We will now look at clinical features of Mycobacterium avium complex. Mycobacterium avium complex infection is acquired through inhalation or ingestion of the organism, with most infections in HIV-infected patients believed to occur through colonization and invasion of the gut mucosa. Disseminated Mycobacterium avium complex disease is characterized by fever, night sweats and weight loss. The gastrointestinal tract is frequently involved and clinical manifestations include nausea, vomiting, watery diarrhea and abdominal pain. At physical examination, hepatomegaly, splenomegaly and lymphadenopathy are very common, and elevations of serum alkaline phosphatase, lactate dehydrogenase and anemia are the most frequent laboratory findings. Other non-tuberculous mycobacteria, including Mycobacterium genevens, Mycobacterium intracellulare, Mycobacterium haemophilum, Mycobacterium simiae, Mycobacterium zenith, Mycobacterium scrofulaceum, Mycobacterium marinum and Mycobacterium fortuitum, have also been described as a cause of disseminated infection in HIV-infected patients. Although Mycobacterium avium complex can commonly be isolated from sputum, pulmonary disease associated with Mycobacterium avium complex is rare. Patients should have a repeatedly positive culture in sputum, an infiltrate on chest radiograph, absence of other lung pathogens, and preferably biopsy specimens showing acid-fast bacilli in abnormal lung tissue. However, the isolation of Mycobacterium avium complex in the respiratory or gastrointestinal tract in those patients who have CD4 plus T lymphocyte counts less than 50 cells per microliter represents a high risk for the development of Mycobacterium avium complex bacteremia. In this case, prophylaxis or treatment should be considered. The most frequent non-tuberculous mycobacterium isolated from sputum in HIV-infected patients is Mycobacterium kansasi. Patients who have Mycobacterium kansasi infection tend to have a low CD4 plus T lymphocyte count, that is less than 50 cells per microliter, and the clinical and radiologic manifestations are not different from tuberculosis. The isolation of Mycobacterium kansasi from sputum is always considered diagnostic of pulmonary disease, since colonization is uncommon. We will now focus on treatment. Let's begin with therapy for Mycobacterium avium complex. Treatment regimens should include a macrolide, such as clarithromycin or azithromycin, plus ethambutol. The addition of rifabutin should be considered, since triple therapy has been associated with a reduction in relapses and in the emergence of resistant strains. Aminoglycosides and quinolones may be useful in macrolide-resistant cases. If ART is to be used, it is important to recognize potential drug interactions between clarithromycin and both non-nucleoside reverse transcriptase inhibitors, abbreviated as NNRTIs, and protease inhibitors. In general, as with other opportunistic infections, therapy for disseminated Mycobacterium avium complex is for life. However, in situations where CD4 plus T lymphocyte counts remain greater than 100 cells per microliter after 6 to 12 months of ART, patients are at low risk of recurrence of Mycobacterium avium complex and the treatment can be stopped. We will now discuss treatment of other non-tuberculous mycobacteria. Mycobacterium kansasi is the second most frequent cause of pulmonary and disseminated non-tuberculous mycobacterial disease. The treatment consists of a daily regimen of rifampin, rifampicin, or rifabutin, isoniazid and ethambutol for 12 to 18 months. Mycobacterium genevents and Mycobacterium haemophilum are resistant to isoniazid, pyrazinamide and ethambutol. Mycobacterium genevents may be treated with a regimen similar to MAC and Mycobacterium haemophilum with a combination of rifampin plus another active anti-tuberculosis drug, such as ciprofloxacin, doxycycline, clarithromycin or amikacin. Mycobacterium simii and Mycobacterium zenith are susceptible to isoniazid, rifampin and ethambutol and should be treated for 12 months. Mycobacterium scrofulaceum therapy requires surgery and isoniazid plus rifampin for 24 months with amikacin for 2 to 3 months. Mycobacterium marinum is resistant to isoniazid and pyrazinamide. Minocycline or clarithromycin or rifampin plus ethambutol for 3 months are possible therapies. Mycobacterium fortuitum therapy consists of amikacin plus cefoxitin plus ciprofloxacin for 1 month followed by quinolone plus clarithromycin for 3 to 6 months. Prophylaxis for Mycobacterium avium complex may be provided in patients who have a CD4 plus T lymphocyte count below 50 per microliter with azithromycin, 1200 mg per weekly, but is not systematically prescribed if ART may be quickly initiated leading to immunorestoration. Primary prophylaxis may be discontinued in patients treated with HART who show an increase in CD4 plus T lymphocyte count to above 100 per microliter for at least 3 months and should be reintroduced if the CD4 plus T lymphocyte count decreases to less than 50 to 100 per microliter. And now we will focus on parasitic infections. Let's begin with toxoplasmosis. Toxoplasmosis, caused by Toxoplasma gondii, an obligate intracellular protozoan, is a common opportunistic infection in patients with AIDS. It has a prevalence ranging from 10 to 40% in Europe, the Caribbean area and Africa, to 5 to 10% in USA. This is due to the different prevalence of Toxoplasma gondii infection in the general population of these areas. Toxoplasmosis occurs as a result of the reactivation of latent T. gondii infection that has persisted in the CNS or extraneural tissues after earlier acute infection. Toxoplasmosis usually occurs late in HIV disease, when the CD4 plus T lymphocyte count is less than 100 per microliter. The CNS is by far the most common site of toxoplasmosis and the majority of patients have encephalitis. Retinitis, pneumonitis and myocarditis are less common manifestations. Toxoplasmic encephalitis, abbreviated as TE, commonly manifests as single or multiple intracerebral abscesses, with focal neurologic signs and constitutional symptoms that progress over a few days or weeks. Fever and headaches are present in 40 to 70% of cases, neurologic dysfunction including confusion and lethargy in 40% of cases, focal CNS deficits in 50 to 60% of cases, and seizures in 30 to 40% of cases. The constellation of fever, headaches, mild neurologic deficit or any unexplained neurologic symptoms should suggest the diagnosis of toxoplasmic encephalitis, as shown in Figure 94.6, and prompt computed tomography, CT, scanning or magnetic resonance imaging, MRI. MRI is more sensitive than CT scanning. Toxoplasmic abscesses are typically contrast-enhancing lesions surrounded by edema. There may be a mass effect, with displacement of the ventricles. Most patients will have specific antitoxoplasmal antibodies, indicating past infection. In most cases of encephalitis, the diagnosis of toxoplasmosis is presumptive, made on clinical radiologic criteria and confirmed by the therapeutic response. Appropriate treatment is therefore especially important, both because the response to therapy is the main criterion for diagnosis of TE, and because early initiation of therapy gives the best prognosis. Treatment consists of initial acute therapy over 3 to 6 weeks followed by secondary prophylaxis to prevent reactivation. The combination of pyrimethamine 100 mg loading dose followed by 50 to 75 mg per day orally and sulfadiazine 4 to 6 grams per day is the first-line acute therapy. These drugs act synergistically by blocking the folic acid pathway of tachyzoids, but have no effect on the cyst forms of the parasite. Folinic acid 25 mg per day orally should be given as well to prevent bone marrow toxicity. Clinical improvement occurs within 5 to 10 days. The diagnosis of toxoplasmic encephalitis is confirmed by a decrease in both neuroradiologic and clinical abnormalities. The duration of acute therapy is 6 weeks. In case of intolerance to sulfonamides, sulfadiazine should be replaced by clindamycin, 2.4 grams daily in 4 doses, intravenously or orally. Other alternative regimens include high-dose intravenous trimethoprim sulfamethoxazole, atavaquone in association with pyrimethamine, or sulfadiazine or azithromycin with pyrimethamine. Efficacy of the addition of steroids in case of perilesional edema is not established. Secondary prophylaxis is with pyrimethamine 25 mg per day orally plus sulfadiazine 2 grams per day orally, or clindamycin 1.2 to 1.8 grams daily until a CD4 plus T lymphocyte count of greater than 200 per microliter for more than 3 months is reached with ART. This combination is also effective as primary prophylaxis for pneumocystis jirovecii pneumonia. If clindamycin is used, aerosolized pentamidine should be added for pneumocystis jirovecii pneumonia prevention. Trimethoprim sulfamethoxazole or atavaquone are potential, poorly evaluated, alternatives. Pause the video and carefully scrutinize Figure 94.6 illustrating the diagnosis and management of cerebral toxoplasmosis in HIV-positive patients before advancing to the next slide. Next we will discuss primary prophylaxis. Toxoplasma seropositive patients who have a CD4 plus T lymphocyte count below 100 per microliter should receive prophylaxis against toxoplasmic encephalitis. The double-strength tablet daily dose of trimethoprim sulfamethoxazole is recommended. Alternative regimens in patients who cannot tolerate trimethoprim sulfamethoxazole include dapsone pyrimethamine or atavaquone, with or without pyrimethamine. Prophylactic monotherapy with dapsone, clindamycin, pyrimethamine, azithromycin or clarithromycin is not recommended. Primary prophylaxis against toxoplasmic encephalitis should be discontinued in patients treated with heart showing an increase in CD4 plus T lymphocyte count to above 200 per microliter for at least 3 months. Discontinuation of prophylaxis in patients where CD4 plus T lymphocyte counts have increased to 100 to 200 cells per microliter has not been carefully evaluated. Prophylaxis should be reintroduced if the CD4 plus T lymphocyte count decreases to below 100 to 00 per microliter. We will now discuss intestinal parasites. Cryptosporidiosis is a worldwide protozoan infection that is more prevalent in lower-income countries. It can affect normal hosts but is particularly severe in immunodeficient patients. Human cryptosporidiosis is generally caused by Cryptosporidium parvum, which is transmitted primarily by the fecal-oral route through person-to-person transmission or indirectly. Outbreaks from municipal water, person-to-person transmission and animal-to-person transmission have been described. The illness is acute enteritis. Diarrhea is the main clinical symptom, ranging in severity from mild diarrhea to cholera-like, watery diarrhea. Abdominal cramps, nausea, vomiting and anorexia usually accompany the diarrhea when it is moderate or severe. Fever is uncommon and may be due to other concurrent infections. The severity of the disease is more pronounced in patients with CD4 plus T lymphocyte counts less than 50 per microliter. Cryptosporidiosis may rarely involve the gallbladder, the biliary tract and the pancreatic ducts, leading to cholecystitis and pancreatitis. Diagnosis is based on the identification of the parasite in feces, in tissue specimens or in other fluids, using a modified acid-fast stain such as the Zeal-Nielsen stain. Treatment of cryptosporidiosis is essentially symptomatic and the best option for therapy and prevention is the restoration of immune function using potent ART. The same is true for microphorидiosis due to encephalocytozoon intestinalis or enterocytozoon BNUC, and for cyclosporiasis. Isosporosis is the only infection for which effective treatment with trimethoprim sulfamethoxazole has been validated. We will now discuss bacterial infections. Bacterial infections as a group are the most common infectious complication of HIV disease, with increased risk for infections caused by common bacterial pathogens, e.g. Streptococcus pneumoniae, Haemophilus influenza, Salmonella species. The introduction of potent ART has been associated with a decline in the incidence of community-acquired and nosocomial bacterial pneumonia. However, the proportion of hospitalizations due to bacterial infections has increased as rates of pneumocystis jirovecii pneumonia and other opportunistic infections have declined to a greater extent. We will now discuss bacterial pneumonias. The incidence of community-acquired bacterial pneumonia is markedly higher, 3 to 5-fold, among HIV-infected patients than among age-matched HIV-negative persons. Risk factors for the development of bacterial pneumonia include lower CD4+ T lymphocyte counts, intravenous drug use, and cigarette smoking. A previous history of pneumonia, low serum albumin, and a lack of receipt of the pneumococcal vaccination when the patient had a CD4+ T lymphocyte count greater than 200 per microliter are all associated with an increased risk of pneumococcal pneumonia. The clinical presentation of bacterial pneumonia in HIV-infected patients is indistinguishable from that in HIV-negative patients. The pathogens most commonly responsible for bacterial pneumonia are Strep pneumoniae and Haemophilus influenza. Other organisms that may cause disease include Moraxella catarrhalis, Klebsiella pneumoniae, and Staphylococcus aureus. Empiric therapy should be based on guidelines for the general population. Bacteremia in the setting of pneumonia occurs more commonly in HIV-infected than in HIV-negative patients. Increased rates of bacteremia with pneumococcal and Haemophilus influenza pneumonia have been documented. Bacteremia may also occur with other pathogens responsible for pulmonary infections, e.g. Pseudomonas aeruginosa. Prevention of bacterial pneumonia should include smoking cessation and anti-pneumococcal vaccination in individuals with CD4+ T lymphocyte counts above 200 cells per microliter, as well as annual influenza vaccination. We will now discuss skin infections. Bacterial skin infections in HIV-infected patients may vary from impetigo to folliculitis to cutaneous abscesses. Cutaneous abscesses are often associated with intravenous drug use as well. Recurrences may be more frequent than in the HIV-negative population, but physical findings and responsible organisms, Staph aureus and Streptococcus species, are similar. A significant increase in subcutaneous and soft tissue abscesses associated with community-acquired methicillin-resistant Staphylococcus aureus, abbreviated as MRSA, has been noted in the last few years in the USA among HIV-infected individuals. Aggressive treatment with surgical drainage and appropriate antimicrobials is necessary. Bacillary angiomatosis is a distinct skin infection specifically associated with HIV disease. The condition is caused either by Bartonella henselae, the organism also responsible for cat scratch disease, or by Bartonella quintana. The clinical appearance is of very erythematous subcutaneous nodules that may occasionally resemble Kaposi's sarcoma, as shown in Figure 94-7. Lymphadenopathy may be associated with these skin findings. Much less frequently, Bartonella henselae has been identified as the cause of more deeply seated infections, including endocarditis, osteomyelitis and hepatic lesions, peliosis hepatis. Diagnosis of the skin infection may be based on the characteristic appearance, but biopsy may be carried out to rule out other causes, and it is necessary to diagnose solid organ involvement. Histology shows vascular proliferation and mixed inflammatory cells. Warth and starry staining reveals the organism. Treatment with azithromycin, Bartonella henselae, or doxycycline, Bartonella quintana, for 1 to 2 months for skin disease, and longer for other sites of infection is effective. We will now discuss enterocolitis. Among the bacterial pathogens causing diarrhea in HIV-infected patients are non-typhoidal Salmonella species, Shigella flexneri, Campylobacter jejuni and Clostridium difficile. Shigella and Campylobacter spp. Infections manifest similarly. Patients note severe diarrhea, which may be bloody, associated with abdominal cramping, nausea and fever. Diagnosis is by stool culture. These infections may both be treated with oral quinolones, although resistance to quinolones is increasing. Non-typhoidal Salmonella species infections may present either with or without diarrhea and other symptoms of colitis. In patients without gastrointestinal symptoms, the infection may manifest solely as fever without any localizing findings. The occurrence of Salmonella bacteremia is more common in patients with HIV infection than in HIV seronegative groups. In addition, relapses of bacteremia are common. Unlike the recommendations for patients who are not immunosuppressed, even Salmonella infections limited to the gastrointestinal tract should be treated in HIV-infected patients. Treatment is usually with ciprofloxacin, dosed at 500 mg every 12 hours for 2 to 4 weeks, and suppressive therapy with ciprofloxacin is often used because of the risk of relapse. Infection due to Clostridioides difficile may be more severe in HIV-infected patients, and these patients are more likely to have relapses and chronic symptoms. Antibiotic use and hospitalization are associated with the development of infection, just as they are in HIV-negative patients. Clostridioides difficile may also occur as a community-acquired infection in HIV-infected patients. Treatment is with oral metronidazole or vancomycin. Pause the video and carefully scrutinize Figure 94-7 illustrating typical appearance of bacillary angiomatosis before advancing to the next slide. We will now progress to integrons. The accessory genes on plasmids and transposons are encoded by elements called integrons. Integrons are composed of segments of DNA that can capture and excise gene cassettes coding antibiotic resistance genes. To disseminate, the integron first must insert into a plasmid or transposon. Integrons contain an integrase that catalyzes the incorporation and excision of the cassette into the integron and a promoter that mediates the expression of the resistance determinant. Both are situated 5' to the cassette. The cassettes are small segments that usually encode a single antibiotic resistance determinant. Hundreds of antibiotic resistance cassettes have been characterized. At the 3' end of each cassette is a variable region called the cassette attachment, abbreviated as ATTC, site, which contains the sequences recognized by the integrase for incorporation of the gene cassette into the integron. Several classes of integrons have been defined based on the sequence of the integrase and their preference for certain transposons. Most antibiotic resistance integrons belong to class 1. A single integron may contain multiple antibiotic resistance cassettes in tandem, all of which are controlled by the single integron promoter. However, transcription of tandem cassettes can terminate prematurely, such that the cassettes closest to the integron promoter are transcribed at the highest level.